Picture this. You're standing in a dimly lit hospital room, holding a syringe of a powerful IV opioid like Dilaudid or fentanyl. In the bed next to you, a patient with a shattered femur has been begging for relief for the last hour. Their pain is an absolute 10 out of 10. Making the jump from textbook nursing theory to real, high-stakes patient care is a massive leap. Our goal today is to bridge that gap, giving you the practical clinical judgment of a veteran bedside nurse. In that moment at the bedside, you face a brutal internal conflict. You desperately want to treat your patient's severe agony, but as you look down, you notice their breathing seems a bit shallow. Pushing that medication could completely stop their lungs. Before you ever push an opioid, your absolute first priority is assessing the ABCs: airway, breathing, and circulation. Specifically, you have to count their respiratory rate. For standard hospital practice and the NCLEX, the absolute cutoff is 12 breaths per minute. If they are breathing slower than that, you hold the dose and notify the provider immediately. Safe pain management requires a constant, active calculation of safety margins. You are evaluating the patient's entire physiological picture, balancing the precise level of pain relief against the immediate risk to their respiratory drive. Often, you will encounter terrified patients who are in severe acute pain but actively refuse IV medication. They sit in agony because they are genuinely afraid of getting hooked on the drugs. It is your job to explain the physiology clearly. Physical dependence and tolerance are normal, expected bodily adaptations to long-term use. The body simply adjusts to its environment. Addiction is a complex psychological disease characterized by a total loss of control and compulsive drug seeking despite harmful consequences. Taking an opioid for a few days to recover from a shattered bone does not spontaneously create that psychological disease. For postoperative recovery, doctors frequently order a PCA, or a patient-controlled analgesia pump. This machine is programmed with a specific amount of medication and a safe lockout interval, allowing the patient to deliver their own dose of pain relief by simply pressing a button. There is one absolute safety rule with a PCA pump. Only the patient is allowed to press that button, not the nurse, and definitely not well-meaning family members. The entire safety mechanism relies on the patient actually being awake enough to physically trigger the dose themselves. Providing clear clinical education addresses these fears directly. When a patient understands why the pump is safe and how the physiological adaptations of the drug actually work, they can move forward with a treatment plan that would otherwise cause them significant anxiety. When it is time to administer an IV opioid, you must push the medication slowly over 2 to 3 minutes. Pushing it faster shocks the patient's system, triggering a massive release of histamine that causes sudden severe nausea, flushing, and intense itching. Look at these two intersecting pain pathways. If we use multimodal analgesia, we combine non-opioids like NSAIDs with opioids to attack the pain from multiple angles. This cross-section of the brain illustrates a crucial physiological rule. Sedation always precedes respiratory depression. The arousal centers in the outer cortex are highly sensitive to opioids and go to sleep first. The primitive respiratory centers deep in the brainstem are slightly more resilient, meaning the patient loses consciousness before they lose the physical drive to breathe. We monitor this decline using the Passero Opioid-Induced Sedation Scale, or POS. If you wake the patient and they answer your question but then drift off to sleep right in the middle of the conversation, they have hit POS level 3. Their arousal center is shutting down. You must immediately hold any further opioid doses and actively prompt them to take deep breaths. Testing a patient's conversational engagement requires you to walk up to the bed, physically stimulate them, and ask direct questions. Recognizing the subtle clinical gap between exhaustion and chemical sedation is your primary defense against a fatal overdose. If a patient slips past level 3, you enter a medical emergency. At POS level 4, the patient is completely somnolent. They offer minimal or zero response to a hard sternal rub. At this stage, you look for the opioid overdose triad. First, meiosis, pinpoint pupils barely reacting to light. Second, a severely decreased level of consciousness. Third, respiratory depression, with the breathing rate dropping dangerously low to 6 or 8 breaths per minute. Do not leave the room. You hit the call button, trigger the rapid response team, and instantly prioritize the airway. If they are completely unresponsive, you physically open their airway by tilting the head back and lifting the chin into a jaw thrust position. If they are not initiating breaths on their own, you grab the bedside ambu bag. You plug it into the wall, crank it all the way up to 15 liters of 100% oxygen, secure the mask over their face, and begin manually ventilating their lungs. In a respiratory code, mechanical intervention is always your first line of defense. You must force oxygen into their failing lungs manually to protect the brain while your team prepares the pharmacological reversal. Once the airway is supported, the immediate pharmacological treatment is naloxone, commonly known as Narcan. Narcan is an opioid antagonist with a higher affinity for mu receptors in the central nervous system. It aggressively knocks opioid molecules out of their slots, taking their seat and instantly lifting respiratory suppression. But the reversal is brutal. By suddenly ripping every opioid molecule away, you trigger acute withdrawal. The patient will often snap violently awake. Their heart rate skyrockets, they are highly agitated, and their severe original pain returns instantly. Narcan is fast but short-acting, wearing off in 30 to 120 minutes. Meanwhile, the IV opioid remains active for 4 hours. When Narcan devises the receptors, the opioid reattaches, risking fatal respiratory arrest. Prepare suction for withdrawal vomiting and monitor continuously for repeat Narcan doses. A successful reversal shifts the crisis from an acute arrest into a prolonged, highly volatile recovery phase. The patient remains at high risk for hours, requiring your constant presence to manage both their pain and the inevitable pharmacological rebound. The fear you feel standing at the bedside with that first syringe is completely valid. But by applying specific physiological frameworks, you replace hesitation with calculated professional execution. Remember your core rules. First, anticipate the low and slow vitals. Opioids depress the system, so you must secure the airway and withhold the medication if the respiratory rate drops below 12. Second, ditch the doorway assessment and use the POS scale. The cortex goes to sleep before the brainstem, meaning sedation will always serve as your early warning system for respiratory depression. Third, administer your IV pushes slowly to protect the patient from a histamine shock. And always respect the half-life trap. Narcan works fast, but the opioid outlasts it. Mastering these concepts allows you to aggressively treat a patient's agonizing pain while maintaining a strict safety margin. This ability to integrate pharmacology with bedside assessment is the foundation of competent nursing practice. To keep building your clinical confidence, hit the like button, subscribe to the channel, and share your own bedside experiences in the comments below. Visit SuperNurse.ai for more resources to support your professional development.